Today's lecture will provide an in-depth overview of alcoholic pancreatitis. We will discuss the underlying mechanisms, diagnostic criteria, and management strategies. Topics covered include cytokines, histopathology, pancreatic stellate cells, gut microbiome, epigenetics, inflammatory pathways, autoimmune pancreatitis, imaging interventions, oxidative stress, pancreatic stenting, immune therapy, and pancreatic steatosis. Let's begin. The immune response in alcoholic pancreatitis involves a complex interplay of cytokines and chemokines. Chronic alcohol intake increases gut permeability, allowing endotoxins to enter the bloodstream. Pro-inflammatory cytokines like TNF-alpha, IL-1 beta, and IL-6 are released, attracting immune cells to the pancreas. Chemokines like MCP1 and MIP1 alpha further facilitate immune cell migration, perpetuating the inflammatory response and activating fibrogenic pathways. This dysregulation of cytokine and chemokine networks is key in the development of alcoholic pancreatitis. Histopathological examination of pancreatic tissue in alcoholic pancreatitis reveals characteristic changes indicative of chronic inflammation and fibrosis. The spectrum of histopathological findings includes acinar cell injury, inflammation, acinar atrophy, fibrosis, and fatty infiltration. To assess disease severity and guide treatment decisions, various classification systems have been developed. The Ranson criteria, Atlanta classification, and CT severity index, CTSI, are commonly employed. These systems, based on clinical, biochemical, and radiological parameters, help objectively evaluate the severity of the disease, predict prognosis, and guide management strategies. Pancreatic stellate cells, PSCs, are important in alcoholic pancreatitis. They become activated in response to chronic alcohol abuse, leading to excessive production of collagen and deposition of extracellular matrix components. This fibrotic response contributes to the structural changes and dysfunction in the pancreas. Understanding PSC activation and the fibrotic process is essential for developing targeted therapies for alcoholic pancreatitis. The gut microbiome, composed of trillions of microorganisms, plays a crucial role in maintaining gut homeostasis and modulating systemic immune responses. In the context of alcoholic pancreatitis, the dysbiosis observed in the gut microbiome contributes to disease progression. Altered gut microbiota composition leads to an increased production of damaging metabolites, such as lipopolysaccharides, LPS, and ethanol-derived acetaldehyde, which exacerbate the inflammation in the pancreas. Therapeutic interventions targeting the gut microbiota, such as probiotics, prebiotics, and fecal microbiota transplantation, show promising potential in ameliorating alcoholic pancreatitis by restoring microbial balance and reducing intestinal permeability. Chronic alcohol consumption has been shown to induce epigenetic modifications, including DNA methylation, histone modifications, and non-coding RNA dysregulation. These epigenetic alterations result in changes in gene expression patterns within the pancreas. Several key genes involved in inflammatory pathways, oxidative stress response, and pancreatic cell apoptosis have been found to be differentially expressed in alcoholic pancreatitis compared to healthy individuals. The identification of these gene expression changes provides valuable insights into the molecular mechanisms driving the development and progression of alcoholic pancreatitis and may pave the way for targeted therapeutic strategies. Alcoholic pancreatitis is characterized by the activation of inflammatory pathways, specifically NF-kappa. This activation leads to the production of pro-inflammatory genes and an amplified inflammatory response in the pancreas. Chronic alcohol exposure triggers NF-kappa signaling, perpetuating inflammation and causing tissue damage. Targeting NF-kappa may offer potential therapeutic benefits, differentiating between autoimmune pancreatitis, AIP, and alcoholic pancreatitis is challenging due to similar clinical and radiological features. However, serological markers, imaging findings, corticosteroid response, and histopathology can aid in distinguishing these entities. Accurate diagnosis is crucial for appropriate management and optimal patient outcomes, requiring a multidisciplinary approach. Pancreatic necrosis, a severe complication of alcoholic pancreatitis, requires prompt management to prevent life-threatening complications. A multidisciplinary approach involving gastroenterologists, interventional radiologists, and pancreatic surgeons is essential for the optimal management of pancreatic necrosis. Image-guided interventions, such as percutaneous drainage and endoscopic necrosectomy, have revolutionized the management of pancreatic necrosis. These minimally invasive techniques allow for targeted removal of necrotic tissue, reducing the risk of infection, minimizing surgical interventions, and improving patient outcomes. However, proper patient selection, expert technique, and close monitoring are crucial for the successful implementation of these interventions. Chronic alcohol consumption leads to oxidative stress in the pancreas, causing tissue damage and inflammation. Mechanisms include increased lipid peroxidation, mitochondrial dysfunction, NADP oxidase activation, and reduced antioxidant levels. Understanding these mechanisms is crucial for developing treatments for alcoholic pancreatitis. Alcohol use disorder increases the risk of acute pancreatitis. Prophylactic pancreatic stenting, placing a stent in the pancreatic duct, may help prevent this condition. More research is needed to determine its effectiveness and identify the suitable candidates. Immune checkpoint inhibitors have shown promise in the treatment of severe alcoholic pancreatitis by regulating immune response and reducing inflammation. Further studies are required to determine their effectiveness and safety in a larger patient population. Pancreatic steatosis, characterized by aberrant lipid accumulation within the pancreas, has drawn attention as a potential contributor to the development and progression of alcoholic pancreatitis. Chronic alcohol abuse disrupts lipid metabolism and promotes triglyceride deposition within pancreatic acinar cells. Pancreatic steatosis triggers a cascade of events, including cellular injury, inflammation, oxidative stress, and ultimately, pancreatic fibrosis. It may act as a cofactor or modulator in conjunction with other key factors contributing to the pathogenesis of alcoholic pancreatitis. Recognizing the role of pancreatic steatosis could provide valuable insights into disease mechanisms and guide the development of targeted therapeutic strategies. In conclusion, alcoholic pancreatitis is a complex disease with various mechanisms involved. Understanding topics such as cytokines, histopathology, gut microbiome, and more is vital for diagnosing and managing patients effectively. Collaboration among different specialties is crucial for improved patient care and advancements in the field. Thank you for your attention and keep exploring the field.